followed by 10 minutes of comments by Manon. Go ahead.
Oh, thank you so much, Damian. That was a really kind introduction. It's so nice to be here today. As Damian said, I was fortunate enough to come to the Netherlands and be a short-term fellow last year, which was a really wonderful experience. So it's great to be part of this conference. Thanks, especially to Damian for chairing, for everyone at the RIAS for organizing this conference, and to Manon, Parry for their comments. In this short talk, I'm going to briefly introduce my book project, which I'm working on at the moment, and then speak specifically to the paper that I shared from which it comes. So my book, which is entitled In Her Hands, Women Protesting the AIDS Epidemic in the United States, examines the underappreciated impact of HIV/AIDS on women and their role in framing the fight against the disease since the 1980s. Set against the backdrop of the politics and culture of the modern United States, In Her Hands centers the actions of women who have fought to secure recognition as people living with and at risk from HIV/AIDS in the male-oriented medical political complex. But securing state support always brought the risk of state interference. Women constantly navigated the tension between needing access to state-funded services, while at the same time needing to protect themselves from state interference, as state support easily tipped to state coercion. The history of AIDS in women therefore opens ways to examine the relationship between grassroots activism and political action at the intersection of racial, class, and gender discrimination. And that kind of interaction is something that I'm really interested in exploring. The question that animates my book then is how, when, and on what terms did women secure state recognition and support free from discriminatory regulation? And what can this tell us about the relationship between the state and women's status in the modern United States? In addressing this question, I argue that many of the elected officials, prison administrators, healthcare providers, and others responsible for shaping the official response to the AIDS crisis responded more quickly and proactively to women's claims and demands when they involved infants and children. Reflecting the politicization of children and the unborn during the Reagan era, the state's proactive response to the needs of infants played out in the early response to HIV, as diagnosticians and doctors first realized that women could contract the virus when their children became sick. The discovery of AIDS in women sparked debates over how to prevent mother-to-child transmission that included suggestions which threatened women's reproductive choices and which overlapped with attempts to police pregnancy, especially along the lines of race and class in the 1980s and 1990s. My paper today explores these themes, asking how battles over reproductive rights, and especially abortion during the Reagan era, impacted efforts to address AIDS in women. In addition to contributing to burgeoning scholarship that brings more fully women's voices and perspectives into accounts of the US epidemic, I'm hoping that this research will demonstrate how the response to HIV in women intersected with histories of HIV criminalization and the criminalization of pregnancy, in turn revealing the punitive potential of the states when dealing with public health crises. And I'm now going to give a quick overview of the paper that I shared. In 1985, after doctors first learned that women could transmit HIV to newborns during pregnancy, childbirth, or breastfeeding, the question of how to prevent the birth of sick infants became a key political and public health issue, with the different suggestions providing a snapshot into the competing arguments around abortion and reproductive rights in the 1980s. With its official anti-abortion position, members of the Reagan administration balked at the suggestion of some, including Reagan's Surgeon General, Charles Everett Koop, to recommend abortion as a prevention option. The administration likewise refused to accept public health advice to endorse contraception and frank sex education as HIV prevention. Instead, as politicians and public health officials argued whether to mandate states to offer AIDS testing to pregnant women, public figures such as James Curran, AIDS Program Director of the CDC, began calling for the mandatory mass testing of women of all women of childbearing age, advising those who tested positive to refrain from conceiving in the future. In the context of an administration working to outlaw abortion and restrict women's access to affordable reproductive healthcare services, and before the introduction of effective HIV treatment, women's health advocates such as Faye Wattleton, president of Planned Parenthood, worried that the government could only achieve its goal of preventing the birth of HIV-positive infants if HIV-positive women never had children. These proposals had particularly worrisome implications for women of color, long denied freedom over their reproductive choices. The passage of HIV criminalization laws at the same time raised the stakes of efforts to learn a pregnant woman's HIV status. Beginning in the late 1980s, lawmakers in 16 states introduced criminal legislation targeting people living with HIV, efforts which the federal government quickly legitimized through the passage of the Ryan White Care Act in 1990, which gave federal funding only to states willing to use criminal laws to prosecute a HIV person's exposure of others to HIV. In addition to criminalizing sexual activity, the scope of which sociologists such as Trevor Hope have outlined well, the Ryan White Care Act also made possible the criminalization of HIV-positive women's pregnancies. HIV testing thus became interwoven with structural inequalities beyond homophobia, including the historic struggle over reproductive justice. The criminal charges facing HIV-positive pregnant women paralleled those facing pregnant women who used substances in this period. In the 1980s, as many scientists, journalists, and government officials created a frenzy over a perceived crack baby epidemic in primarily low-income and Black communities, law enforcement arrested and charged hundreds of women for actions taken during their pregnancies, highlighting their racist implementation and reflecting broader racial disparities in criminal justice in this period. And since police disproportionately targeted Black women, despite Black and white women using substances at similar rates. The deep investment of women in the health of their pregnancies, future children, and newborns undermined policies and rhetoric casting them as a threat to HIV in children. In 1993, the National Institute of Allergy and Infectious Diseases launched Trial 076, the first federally run trial to include women, which was designed to prove whether the experimental antiretroviral drug, AZT, prevented perinatal transmission of HIV. The 3-year trial involved over 400 predominantly Black and Latina pregnant women. As women doctors and women-led organizations, caucuses, and committees hotly debated the ethics of 076, especially of enrolling mostly Black women given the toxicity of AZT and the history of experimentation on Black people in the United States. Many women expressed their desire for the trial to go ahead, eager to find a treatment that would stop them transmitting the virus to their infants. The trial went ahead as planned with groundbreaking results, finding that AZT reduced the risk of perinatal transmission from 25% to less than 8%. In 1994, the US Public Health Service approved the use of AZT during pregnancy, which led to a sharp drop-off in pediatric AIDS cases from the mid-1990s onwards, its approval giving women the possibility of reducing the risk of perinatal transmission without threatening their right to choose when and whether to have children. The approval of the use of AZT in pregnancy in 1994 ended many of the political debates over prevention, abortion, and motherhood. Nonetheless, women have continued to live with some of the consequences of early assumptions about their responsibility to prevent HIV transmission, even as the treatment environment has changed radically since the early 1980s. For example, in the paper that I shared, I wrote about the case of a HIV-positive woman named Cecilia Sliker, who in 2008 was prosecuted for not seeking treatment for her unborn child, fearful of what her son's father might do to her on learning of her HIV status and signaling the close link between HIV in women and domestic violence. Amid the competing public health and political responses to AIDS in women, the strength of the anti-abortion movement during the Reagan era effectively hampered efforts to address AIDS in women. While legal abortion survived the attacks leveled against it in the 1980s and early 1990s, the punitive response to AIDS in women created structural barriers that have hampered women's access to HIV treatment and care ever since. For some, a visit to the doctor resulted in them making unwanted decisions about their pregnancies. For others, the loss of confidentiality from HIV testing risked the loss of custody of their children, or the threat of longer prison sentences, or criminal child abuse or neglect charges. The increasing restrictions placed on women's access to reproductive health care overlapped with the threat of prosecution, which deterred women from seeking care in the first place. To conclude, as I wrote in my paper, disease outbreaks call into question how, when, and on what terms the state uses its power to intervene in crises, and the consequences of state action on people's rights. The experiences of HIV-positive women, coerced into making unwanted decisions about their pregnancies, make clear that state intervention often coexisted with state neglect to shape the experiences of women living with HIV/AIDS. For these women, securing recognition for the sake of gaining access to treatment and services alone was not enough. Vulnerable to state surveillance and regulation, they also needed access to non-discriminatory healthcare that did not threaten their right to decide for themselves about their bodies. In the preceding years, as the treatment environment has changed, women's struggle to make themselves count as individuals, free from prescriptions about their bodies and lives, has continued to drive their AIDS activism. Thank you.
Thank you so much for that, Emma. I'll give the floor immediately to Manon for comments.
Thank you. And I should say thank you very much for inviting me. I'm really pleased to have this opportunity to read Emma's fascinating analysis and also to meet so many of you online, many people in the Netherlands that I haven't even met in person yet, which is a bit of an embarrassment, but hopefully we'll be connecting more from now on. So turning to Emma's paper, Emma, I'm really glad that you're doing this research, even though it's a fairly depressing tale because it seems to suggest that women's activism has largely failed in this area. But we'll come back at the end to that question of impact. But it's a really important story. And as you say, reproductive rights and AIDS have been treated separately by historians, and also within histories of AIDS, particularly the history of AIDS activism, women's activities really haven't received enough in-depth attention. So it's a very important project that you're working on here. And the story you tell relates very clearly to the themes laid out in the keynote by Naomi, but in a very particular way because of America's fraught history with abortion. So I just wanted to begin by summarizing those connections. So with Naomi talking about state responsibility and authority, especially what special powers are accepted by the public during a crisis, the history you tell here shows us how abortion is framed as a kind of permanent crisis. And in the vision of citizenship that was also mentioned in the keynote as being a key part of these issues, women's responsibilities and their citizenship versus citizenship of the fetus, which often exceeds their own individual rights, is of course really relevant for your story. Then relating to the other idea she raised about defending public health measures through a dramatization of threat, you mentioned the media frenzy around crack babies as a comparison to the panic over women infecting their children with HIV. And that made me think, of course, of the much longer history of women represented as reservoirs of disease and a threat to the health of innocent children. And then finally, the notion of shifting ideas about health and how much the limitation of life or rights are warranted in order to promote health in a crisis. The history that you're looking at here is in a context of women's rights already being limited and fragile pre-AIDS. And then, as you note, even as treatment options have improved, the incursion into rights that you describe has been more permanently institutionalized. So I think it's, a great example of the themes of this workshop. And my first question relates really to the interaction between reproductive rights and AIDS, and particularly between the subgroups or competing priorities within subgroups in those interrelated activist circles. So my question is, when you mention feminist organizations actively campaigning against mass testing and criminalization of women with HIV, I wondered if their work connected to the other largely unsuccessful area of women's activism on AIDS, which is the funding and development of microbiocide research. And I wondered if you saw connections between the lack of success in both of those strands, as if they're caused by broader issues with gender and reproduction, and not just the ascending power of anti-abortion politics. So that was one query for me. And then again, focusing on the debate within activist groups, but this time more broadly across AIDS activism, I wondered about potential clashing priorities between gay men and women. And I wanted to know if there was disagreement in those communities, as in France, for example, where women felt quite excluded from ACT UP's agenda because ACT UP was strongly against criminalization to avoid stigmatizing people with HIV any further. But women there who'd been unknowingly infected with HIV because their partners hadn't revealed their positive status, those women wanted male partners to be held accountable, so had a different attitude about the benefits of potential criminalization. So I just wondered if that came up here. You say that men are completely absent from the public debate about the infection of babies, but was that also the case in discussions between women and in their own activism? And if it wasn't present, what do you think it says about the coalitions and compromises made between broader AIDS activism and women's activism in the pandemic? And my second area of comments relates to the history of eugenics and the topic of disability. And the history in your paper seems like an exceptionally American one because of the intersection of the politics of incarceration, abortion restriction, and racism. And yesterday, Giles mentioned faith-based motivations for dealing with public health as resonating throughout all the papers, and it's surely at work in your case here too. And you mention in the paper progressive era eugenics and laws mandating testing of syphilis and other venereal disease to improve the health of the nation. And you hint at the broader issues at work that went into limiting who would be seen as healthy and fit to reproduce, although you don't go into them in detail. And yesterday, Richard Mazzella's paper demonstrated how disability really powerfully reveals new layers in the ways disease threaten the values of the American century. So I'd like to know how the potential disability of the children who would be born with HIV play into your history. You say Republicans didn't want to endorse abortion, but their legislation, like the Ryan White Care Act, surely encouraged it. So is this an example of ableism making abortion okay in practice, even if it wasn't okay to say it out loud? And with the long history of attempts to limit the reproduction of people living in poverty, I'd also be interested in your thoughts about how the attempts to control the reproduction of women with HIV expanded in the time between the two women's stories that you focus on in the paper. So in 1988, when Carol Doe was tested, and this was presumably because of the focus on Haitians as being one of the 4 so-called high-risk groups in the 4 H's, along with hemophiliacs, heroin users, and homosexuals. And then you describe how she encountered the kind of coercive pressure to have an abortion that's experienced by women of color more broadly. But then in 2008, when Cecilia Slicker was arrested for infecting her child with HIV, this comes after the introduction of AZT to reduce the risk of perinatal transmission. So as you note, AZT ended the public debate over the issues, but clearly not the legal restrictions. As a white woman, apparently in an abusive relationship, why was Sliker targeted, do you think? And was this because of poverty? And is this an expansion of the punitive policies, or were white women already part of that earlier focus on limiting the reproduction of women with HIV in the 1980s? And then finally, if I can drone on just a little bit longer, I wanted to return to that issue of a gap between public pronouncements, what's allowed to be said, and actual practice, as it seems like there's some slippage in your paper between statements that never actually led to action, such as mandatory mass testing of all women of childbearing age, and laws that were used, but they may not have been widely applied. And you note that there's little data on the actual numbers of prosecutions based on HIV transmission or exposure. And you mentioned the crack baby media frenzy, and that turned out to not be an actual epidemic, but more of a politically useful tool. And I thought as well of parallels to the panic over fetal alcohol syndrome as well as another example of those kind of media pandemics. And following Inderjeet's interesting remarks yesterday about the interaction between soft and hard power, I kept thinking of the statements and even the laws that you discuss as a kind of PR activity that in reality might not have been so widely implemented. Or maybe the PR activity served to obscure the reality that abortion might indeed be the most likely outcome of putting this much pressure on women not to reproduce if they're HIV positive. So kind of using criminalization as the screen to increase a culture where abortion was an easier choice. So I'd like to know your thoughts on all of that. And thank you for a really interesting read.
Well, thank you so much for those really thorough and insightful comments. So much to think about. I'm glad it's being recorded, the session. So just to start with the relationship between reproductive rights and AIDS and microbiocides, the 5th chapter of my book is about microbiocides and kind of their what their failure, or like what the inability to bring those tools to market tells us about gender equality within HIV prevention and treatment options that has existed since the 1980s. So kind of like a, where you start of the book about women's struggle to be recognized and to be included in criminal trials and to even be counted as being possible to have HIV within the AIDS definition set out by the CDC, thinking about how those same struggles have continued into the 21st century. And I think one of the big themes or areas that kind of links a lot of the points you made together is about private healthcare, privatization, and money. And something that I found in my research about microbiocides was kind of the reluctance of private companies and corporations to fund these treatments because they weren't seen as being as profitable, because the whole point of their design is to be as accessible and as cheap as possible for them to have effect. And in contrast to something like the birth control pill, which is taken every day, so there's constant use, therefore constant profit, microbiocides, some of the different options that were developed were only meant to be used, say, every time you had sexual intercourse, so weren't seen as being as profitable, basically. And there's a reluctance on the part of a lot of organizations to put money behind it, in contrast to PrEP. And I kind of look at the parallels between how microbiocides kind of fail and fall out of a lot of the prevention agenda by the 2010s, in contrast to the rise of PrEP. And, the obvious profitability behind that drug. So thinking about the connections between gender inequality with against the backdrop of economics and these kind of like wider structures. So yeah, it's interesting that you flagged that because I'm really interested in thinking about those connections and how they play out later on, and how they also contrast to thinking about sexual power or women's sexual agency. So when in the early 1980s, where there's such a focus on condoms and kind of male sexual, what can men do to protect themselves in the wake of HIV? There's kind of a disparity or a lack of recognition that a lot of the suggestions are put forward, like condom use, don't account for things like gender power imbalance in relationships. And that's where something like Cecilia Slicker, I think, is interesting in thinking about the connections between domestic violence and HIV and prevention. In terms of debates between and clashing priorities, yeah, I think that the whole within AIDS activist organization, there's kind of a constant tension between, or a lot of these organizations were led by men, like ACT UP, and when women would try to present a more woman-focused agenda, or things that maybe men not consciously meaning to neglect, but just hadn't considered, they needed to account for, often saw those women's issues as being distracting from the main fights they thought that should be waged. And a lot, I think, it's interesting that as a consequence of this, a lot of women within those organizations like ACT UP form splinter groups as a consequence, like the ACT UP Women's Caucus departs from the main ACT UP body over issues like the Trial 076 and what happens, whether to push an agenda for that, or about campaigning to change the CDC definition of AIDS to include women-specific illnesses like cervical cancer. I also have a chapter on queer women's safer sex campaigns. One of the leading organizations is called the Lesbian AIDS Project, and it's led by a woman called Amber Hollibar, who's really awesome. And she, a lot of their safer sex campaigns are very explicit about queer women's sexuality as a kind of contrast to sexual publicity, safer sex publicity that was very male-centered. But that material ends up getting basically censored and attacked by different lawmakers, media, and interesting to think about what that says about the limitations on, again, women's articulation of their own sexual agency at this time. In terms of exceptionality, yeah, I think that I think privatization is, or like not having not universal healthcare, kind of opens up a way for a lot of these arguments that kind of, or there are a lot of private healthcare doesn't allow for kind of value neutral responses to women's health in a way that universal healthcare does. So I feel like it kind of creates space for a lot of the kind of punitive responses to women's health. I look at the rise, for example, of, against the backdrop of defunded women's healthcare spaces, how things like minute clinics and kind of privatized health spaces have filled that gap, but they continue to, where individuals are given kind of like the power to deny or make decisions about women's reproductive health care based on things like religious grounds. And thinking about faith, so I look a bit in this chapter about Surgeon General Koop, and I think he's quite an interesting case for thinking about what conservative, or like the split among conservatives and Republicans as happening at this time. So Koop was an anti-abortionist, spent a lot of his life kind of campaigning around disability rights for children, but this is kind of how I became interested in the relationship between abortion and AIDS. I found a document in the Reagan Library where he basically gives a press conference saying that women who have HIV should be given the option of having an abortion if they wanted it. And this kind of incenses the Reagan administration. They say, well, you're a representative of Reagan's government. How can you go out there and say in front of the National Press Club that we endorse abortions in these cases? And that kind of is where my interest in this topic started, and how he kind of, from a public health perspective, he says, morally I'm against abortion, but we should see it as an acceptable public health route. So kind of in contrast to maybe what I might have assumed as an evangelical Christian, his perspective on the issue might have been. And other conservative figures like Barbara Bush, their response to babies that are born with disabilities or sick are to start often start AIDS houses, so fund kind of institutions that would care for sick children. I think there's interesting in the debates that take place, against the backdrop of women trying to gain recognition as people from HIV, at risk from HIV. Congress is quite quick to pass money that will fund these houses. So I'm conscious that I'm speaking quite a lot, but just the last point about poverty as well and Slyker. So her case is interesting in thinking about how the treatment environment has actually restricted in some cases rights, as opposed to making improving them or expanding them, because the reason that she was prosecuted was because they said that the court said she had the treatment of options were available, in contrast to a woman who was prosecuted, I think in the 80s, and the courts ruled that because there wasn't available treatment, then there wasn't a neglect, an absence of care. Whereas in Slyker's case, that the treatment was there for her to seek, and in not doing so, she had acted criminally against her unborn child. And definitely I think that she was a white woman, but I think probably her class did contribute to the ruling and the discussion around that. I'm going to stop talking because somebody's raised their hand. And yeah, thank you so much. Those comments were so useful.
Yeah, thanks to you both. Thanks, Manon, for those comments. But indeed, right on target. And Emma, the presentation was fascinating. I think your responses to Manon's feedback are also really help us understand where your research is going. I see that Naomi has a question, so I'd like to invite Naomi to go ahead and ask a question.
So thank you. First, just to reiterate what Damian just said, the comments and the paper as well were really thoughtful. And I'm currently writing a book on the history of health activism, so these are issues that I'm especially interested in. Emma, I wanted to raise two things. One is this continuing tension for women activists, including feminists, about the connections between women and children. So women discovered as least as early as the progressive era, if not before, that if they were able to make arguments as mothers or as potential mothers, that they were far more likely to get legal and political gains than if they made arguments as independent working women, for example, something like that. And so it's really fascinating to see that this connection between women as mothers or potential mothers is still such a powerful political force. But I raise this because this became an increasing issue for, especially for feminists by the 1970s and 80s, as to whether they wanted to have women seen as either mothers or potential mothers, right? And so I wanted to ask whether you saw any discussions about what it means that women get identified as involved in the HIV crisis just because of themselves as mothers, right, initially, or for quite a long time. And the other question, and here I know that this is a kind of a third rail that's not discussed very much, but when you discussed COOP, it reminded me in particular, this is a moment in the 1980s of the expansion of the disability rights movement. But the reason I call it a third rail is this is the increasing conservatism and the alliance of many people in the disability rights movement with the Reagan era, in which they argue that protection for disabled infants is absolutely crucial. And they are, in fact, far more likely to find political space with COOP and others in the Reagan administration. And thus, Barbara Bush, for example, while it is a politics of compassion, it is also very much this association with resisting, for example, abortion for identified fetuses with disabilities or something like that. So those are my two questions.
Oh, thank you so much. Really helpful questions. And yeah, I definitely see this kind of being a continuation of some of the earlier history of how women, or how the state is seeing women, how it's treating women, and I guess like how it ties into the idea that women have a hard time making claims on the state as kind of autonomous individuals, besides from their kind of identities as mothers. And I guess I think about it in terms of, I suppose, maybe there's a tension between how the state treats women as in the category of mothers is kind of easier than thinking about kind of lived experiences, which are a bit messier. So thinking about perhaps why there's such a pushback against safer sex material, which kind of outlines the what sex actually involves, or like all the various multifaceted aspects of being a woman versus a woman as a mother, and that's kind of how I think about it when approaching the material I have. But yeah, I think there's discussion about motherhood, and I suppose there is a bit of a split or a tension between, as I was saying, about the women who are involved in the trial. There's a lot of women who are really concerned about wanting to not pass HIV to their children, and where you have some maybe more active women activists further on the left who are saying like we just got to get rid of this whole idea of motherhood, because we should just be fighting for this to gain access to treatment or sex education on our own terms. Some women were saying, well, actually, thinking about lived experience, I would actually like to find out or be involved in a trial that deals with this. So yeah, I feel like a lot of material that came from the Schlesinger Library about women being concerned about loss of custody of their children, and really quite harrowing stories about how women were pitted against or are seen as being harmful to their children because of their infected status. And then thinking about yeah, disability rights movement and conservatism. No, I mean, I think the question of compassionate conservatism is interesting, and how to fit that within a broader definition of activism. And I suppose in this chapter I'm talking about Coop, I kind of have a hard time, or I'm having a hard time rewriting it, thinking about how to categorize him. Was he, because he basically, well, he was quite progressive. Well, that's what I mean. I don't know. Like he didn't condemn. He called for a frank sex education, and he refused to say that abortion was harmful to women. So in the context of the Reagan administration, he was quite progressive. But then how to fit him and the kind of the conservatism of people like Barbara Bush into this broader history of activism? I'm trying to think about what terms to use, and I suppose, you know, because they're quite loaded if you call somebody progressive or radical or that kind of thing. So yeah. Thank you. I hope that answers your questions.
Thanks, Naomi and Emma. Giles, you have a question.
Yeah, thank you, Emma, for this very challenging paper. I'd like to, if I can, just draw you towards the theme of our conference, the American century. I mean, you really have given us a tale of prejudice, bias, violence based on class, race, gender in a quite quite profound way. How do you, from the perspective of your research, view the idea of the public health in the American century? Is it at all? Can it be redeemed in any way, or do you only see that in negative terms?
Do I only view what? Sorry, the idea of the.
Well, just does the idea of an American century have any redeeming features from the research that you're looking at, or does it merely refer to encroachment of a conservative state, surveillance, violence, and so on?
No, and I suppose not. There is scope for public health responses that were more productive in terms of protecting people's rights, or individuals that acted more compassionately. So I don't know if I would say that it has no redeeming features, but I suppose when this history is when the AIDS crisis happens, it's taking place against the backdrop of general kind of narrowing down or gutting of social welfare, and an increasing turn towards punishment and prosecution to deal with social issues, which is why I'm kind of interested in thinking about this in the context of mass incarceration. And one of my chapters is about women in prison, which is probably the least the bleakest story, I suppose. But I guess out of these the harrowing or difficult tales, that the women's activism, and I guess there's not so much in the paper that I shared today. I suppose it's that kind of enduring hope and power of women organizing together, which is where the redeeming aspects of my work come from. So I suppose that's not so much about the public health establishments, but I think the context is probably, the important thing. And I suppose, in some ways, the story of my book, like healthcare becomes more privatized for women, becomes increasingly privatized. I argue that it becomes increasingly ideological, I suppose, and partisan. But undergirding that is ongoing, the persistence of women's struggles for equality and rights and access. So yes and no, I suppose.
Thank you. Very interesting.
Emma, I have a question myself, actually, and I can't remember it, but I think I actually posed this question to you once when you were here. But I'm curious to hear about the the different responses from individual states to federal pressure to impose a certain definition of criminalization of HIV at the state level, because a lot of the political discourse regarding women's rights, and certainly a lot of the policymaking, takes place really at the state level.
Yeah.
Government sort of threatens to withhold funds if they don't toe the line. But I'm curious to hear if what's the spectrum, let's say, of state responses to this? Are there places where states legislatures maybe try to push back against forced criminalization of HIV?
Yeah, sorry.
Yeah, good.
There are, I think there's 5 states that don't ever pass any criminalization legislation, like Maine, Massachusetts, Oregon, and I can't remember the other ones, but yeah, certainly there are attempts to kind of, or I suppose gets back to what Manon was saying about like the gap between rhetoric and like enforcement or like impact on the part of the reason why it's quite difficult to know the exact number of people that have been prosecuted is a question of like, how do you, so, yeah, under what circumstances are people being prosecuted? Sometimes it's often they're grouped, sorry, under existing laws like murder or that kind of thing. So I suppose some states are not as proactive in enforcing a lot of this legislation. And yeah, as you say, in many ways, and a lot of increasingly historians of the epidemic argue that this isn't really a federal story anyway, it is a state story. And there's kind of a lot of disparity, I suppose, in the funding and the experiences of people with HIV, depending on where they live. I think California is quite an interesting example because I think this is right in saying that in the 1980s, LA, I think it was, spent more money on AIDS than the whole of the federal government. I think that was John Bell who said that. If it was not true, then I'll have to ask him. But yeah, so there's huge gaps in funding for services and the response. But I think California is quite interesting because where you have kind of this perception of it as being very liberal and progressive in response to HIV, the prisons that I look at in California and the experiences of incarcerating women with HIV in prison there are awful. And I think it kind of is quite easy, or there's a lot of nuance, I suppose, within even states about how they're responding to different groups around the virus that yeah, really interesting to look at in themselves. But yeah.
Thanks for that clarification. I see actually that we're already out of time. It's amazing how quickly these sessions go. I do not see in the participants list, I don't see our next speaker logged in yet. Yifei Li, is that correct? Is she here, but I'm just not seeing her? If she's not logged in.
Hi, Damian. Sorry
Hey,
to stop
Damian.
you. I've been in touch via email with Yifei, and she told me she will be reconnecting in 2 minutes.
I see her. Perfect. Okay, Yifei, you're logged in, and I see Andrea Flynn.
I finally let my computer work. It's just
no, you're right on time. So that's perfect.
That's good.
So then, Emma, I would like to thank you once again for sharing your research with us, which I still find fascinating and really timely. And so thanks again for participating here. And Manon, thanks again for sharing your comments with us. We are going to move right along to the next presentation in this panel, in panel 4, which will be given by Yifei Li from University College, and she'll be receiving comments from Andrea Flynn. I will go ahead and introduce both Yifei and Andrea before you start. And Yifei, just to reiterate what the structure is. It's 10 minutes presentation followed by 10 minutes comments, in this case from Andrea. After that, you'll be provided the opportunity to respond to Andrea's comments, and then we'll open it up for a general discussion. So Yifei Li is a doctoral researcher at University College London Institute for the Americas. Her research explores the process of policy feedback through a case study of Medicare, a major public health insurance program for the elderly in the United States, of course. Employing historical institutionalism as her major methodology, her research aims to illustrate the development of Medicare from 1965 to 1997 as a program jointly shaped by incremental change and radical reform. The comments will be provided by Andrea Flynn. So nice to meet you finally through this means, Andrea. Andrea Flynn is a senior director at the Insight Center. Prior to joining Insight, she spent 8 years at the Roosevelt Institute, where she was most recently Director of Health Equity. She is the co-author of The Hidden Rules of Race, published by Cambridge University Press in 2017. She frequently writes and speaks about the race and gender dimensions of economic inequality, reproductive health and justice, and health equity. Her writing has appeared in The Washington Post, The Atlantic, Ms. Magazine, New Republic, Time, Vogue, and Cosmopolitan. Her research has examined the legacy and impact of gendered racism in our economy and the role of economic policy in driving racial and gender health disparities. Andrea also teaches courses on reproductive and sexual health, public policy, and economic inequality at the Manon School for Public Health at Columbia University in New York. And Andrea, it's an honor to have you with us today. So thank you very much for that. I will turn the floor over to Yifei. So 10 minutes, Yifei. That will be followed by 10 minutes of comments by Andrea, and then you can respond to Andrea's comments, and then we'll open it up for a general discussion. Go ahead.
I'm going to share my screen as I have a PowerPoint to show you. All right. Could you see my screen? Yeah? Oh, terrific.
We are looking at ourselves, yes.
Ah, yeah.
There
okay,
we go.
so could you see my PowerPoint?
Yes.
Terrific. Today my presentation is about entitled consumers. Entitled consumers: transition of democratic citizenship in Medicare reform. And my presentation proceeds in 4 steps. Firstly, I would like to introduce the main issue this paper attempts to address. And secondly, I will introduce 2 keywords, which is new public management and governmentality as the theoretical foundation of my essay. And in the third part, I will move to the market-oriented approach and discuss its disadvantage and advantages. And fourth and finally, I will analyze its implications on citizenship. So why should we care about this issue? I will give you a little background information, and after that, probably we are going to talk about some heated topics related to this issue. And in 1995, for the first time in over 30 years, conservatives abandoned the bipartisan consensus and launched a revolution in Medicare that saw a profound shift in its agenda from a healthcare program to a healthcare market. And policy analysts and some elected officials began to endorse an alternative to traditional management strategy of Medicare, which is named the premium support, which is a new orientation built around the principle of managed competition. And it means controlling healthcare expenditure, not by imposing stricter regulations, but by allowing private insurers to compete with lower prices, better services, and innovative premiums. However, an unintended consequence of managed competition is perhaps the reconceptualization of citizenship, as well as the relationship between the state and its residents. This essay thus situates Medicare in a broader domain, which is the transition of American healthcare in the 1990s under the principle of reinventing government. With discussion on the impacts of a consumer-directed market, I argue that while imposing state-managed programs to commercial bids enables citizens to discipline the market with their spending power, the new system also invites citizens to be responsible for their choices and accordingly be disciplined by the market. And the birth of Medicare coincides with the first wave of public management reform in the 1960s, which is principally about more rational strategic policymaking and evaluation in the face of the advent of new modernism, namely a period with rapid advances in science and technology, together with the subsequent growth of the evidence-based scholarship in social sciences. It promised a more rationally designed set of government agencies and public programs. And the second wave started from the 1970s, when the dismal prospect of the global financial disturbance and government overreach collectively fostered the belief that the American welfare state has been ineffective and insolvent, and totally constraining on the professions and services users alike. And there also arose a desire to make government more business-like, which means to be less costly, be more efficient, and more responsive. However, as the reform proceeded, there arose another problem. A business-oriented government tended to fragment the public sector and brought about more single-purpose agencies that were hard to work cooperatively to pursue the same overall policy objective. The accountability problem was perhaps another unintended consequence of the reform. Regarding unpopular outcomes, it were often the ministers instead of the agencies that actually implement the policy who got the blame from the media and the public. So the late 1990s saw the shift of agenda from business towards joined-up government and partnerships, which resulted partly from the political awareness that government was losing the public trust because politicians have been exploiting the politics of fear, which means playing on the fear for the collapse of healthcare system and other major national systems. In this period, a number of commentators also started to believe that there was one clear direction toward which the government can build trust and transparency. The direction was called the New Public Management, the NPM, which is a term that covers a very wide range of public management reforms in the 1990s across the world. And particularly in America, NPM is better known as Reinventing Government. Fundamentally, Reinventing Government is a way to sharpen and extend the concept of governmentality proposed by Michel Foucault. Compared with traditional definition of sovereignty that regards governing as controlling a constellation of parties and institutions that comprise the state, governmentality emphasizes the capacity to shape, guide, and direct them. This implies the government should decentralize responsibility and decision-making power down as close to people as possible, with an expectation to reward people for maximizing their self-interest and interest for society as a whole. Thus, governmentality is far more complicated than sovereignty because it consists of various interest groups, with each of them operating with their own values and principles. But the problem lies in four aspects: how to cope with monopoly of powerful interests, how to coordinate them, how to mobilize different interests that are bound to clash, and how to tackle inertia and gridlocks. A market-oriented strategy seems like a simple solution to all four. Exposing state-managed programs to competitive bids come quite in handy when the government is struggling to find well-entrenched professional and institutional powers. A proper combination of administrative orders and market force can also serve as a countervailing power to make healthcare more affordable. Even when the escalating cost is inevitable, the blame is shifted from government to individual providers. Regarding the risk that some essential parties and institutions may prioritize their own interest over public welfare, market providers is a self-regulating power where funding streams are constantly refreshed, and it can form an ongoing discourse between the government and different parties. Gradually, Such approach has moved the state towards an ensemble of institutions, procedures, tactics, calculations, knowledge, and technologies, which together constitute the particular form that government has taken, which is the outcome of governing. So, such market-oriented approach can also address the drawbacks of co-payments by shifting pressure from providers to patients, and consumer-driven market, by contrast, a consumer-driven market, by contrast, enables people to make their own choice based on market rules by positioning healthcare as a consumer issue instead of an issue of basic rights that accompany citizenship. For sure, the roles of citizen and consumer are not mutually exclusive. After World War II, but after World War II, America began to embrace the concept of purchaser as citizen and a consumer-oriented vision of citizenship that highlighted the maximization of individual consumers' self-interest through mechanisms of free market. In this, as I quote, "What is in it for me?" quote, and approach to consumer politics, gender, race, class, or some other experiences are not considered as determining factors when making policy decisions, and distinctions among such identities as citizens, consumers, or voters are all collapsed by the priority of self-interest. And another issue central to this new vision of citizenship is self-responsibility. Within the discourse of consumerism, citizens are regarded as self-regulating individuals, particularly in healthcare. Congruence between the reflexive actor and the notion of the consumerist patient. There is a congruence between the reflexive actor and the notion of the consumerist patient, because both are actively calculating, assessing, and if necessary, countering expert knowledge and autonomy with the objective of maximizing the value of services. In fact, the advantage of active consumers has long been acknowledged by scholars since the 1970s, and it is acknowledged that active consumers can contribute to efficiency of service, quality of Medicare, and user empowerment more broadly. So in overview, the reform of American healthcare towards managed competition is also a transformation of state control from service administrator to consumer of evidence-based medicine, guidelines, and accountability. Choice in this reform is a magic word that perfectly aligned control and empowerment with emphasis on the role of consumer, together with the privileges of citizenship. It is an approach beyond the controversies of marketization and or bureaucratic regulation, as well as submerge or convergence of health systems. It can direct attention towards actors and agency, cultural norms, and formal or informal procedures. And it is also a way, as Newman argues, to, as a quote, rethink government as social and culture, as well as institutional practices. So in this part, I would like to discuss with you, which is also why I came to this conference. The first concept is called the hollow state, which means government agencies choose to share their authority for collective action with non-profit agencies and private firms in a network of mutual dependence. But my question is, what are we studying when we're studying the hollow state? Because in the system of Medicare, there's also a lot of intermediaries. And if professionals are mediators between state and those patients, could we include intermediaries? And is that a triangle between, is there a triangle among professionals and state and patient? Or if there is, how could we place the intermediaries in this triangle? And so this is the end of my presentation. Thank you very much. And if you are interested in my topic or just want to have some discussion with me, just email me, and directly you're more than welcome to discuss this with me. So thank you very much.
Thank you very much, Yifei, for your presentation, and thanks also for posing discussion questions right off the bat that we can discuss later in the group discussion. First, I want to give the floor to Andrea, who has prepared some comments on your paper.
Sorry, I forgot to unmute myself. Hi, everybody. Really good to be with you all. Thank you so much, Yifei, for this presentation. I'm really wishing I were with those of you who are in Middleburg, but glad we can be connected this way. This is a really timely conversation. The growing costs of healthcare in the United States are now really front and center in our politics, and reining in costs by giving the government more power to negotiate prices is really at the center of President Biden's agenda, which is growing increasingly fragile by the day. I also am thinking about how the neoliberal economic ideology that really characterizes the US economy and also our health system has really, we are now at this point in American politics where the sort of the idea of trickle-down economics has really been accepted as a failure. We are living in moments of growing economic inequality, really large gaps in income and wealth, growing disparities in health outcomes that we've seen grow during the pandemic, but also really growing disparities in access to care and quality of care. So I think this is a really interesting and important time to really reflect on the theoretical underpinnings of our health policies and programs, and to consider what might come next, and what we might hope will come next. So I have a few comments about the paper, and then looking forward to discussion afterwards. So this paper highlights the shifts in the US health system that have taken place over the past 5 decades, with a specific focus on the market-based changes that were ushered into the health system in the 90s as part of broader efforts to curtail the scope and role of the federal government. Li examines both the theoretical underpinnings that drove these transitions and points to some of the consequences, both for consumers and the health system more generally. And the paper also considers important questions about how health policy is shaped by, but also influences citizenship and democracy. One context that I keep thinking about and kept turning back to as I read this paper and was jotting notes in the margins was the broader politics of the 1990s in terms of healthcare, but also in terms of other reforms like criminal justice reform and welfare reform that facilitated or perhaps accelerated Medicare's increased marketization. And I just kept thinking about how we really can't consider these economic policy choices, and by extension, health policy choices, independent from the political moments in which they exist. And so I just want to sort of reflect on some of the history that Yifei mentions in her paper. The paper mentions the evolution of public policy reforms that shaped the Medicare program, and I'm really curious about how these shifts are situated within the broader context of social and economic trends over the past 5 decades or so. So the birth of Medicare coincided with a number of public policy changes that occurred in the 1960s. I think it's important to know and to remember that this was a time characterized by significant expansion of federal programs and the intentional inclusion of historically excluded populations into those programs. A wide range of federal legislation during the civil rights era really opened doors of public policy and public programs to Black and Brown Americans who had long been intentionally locked out. This was a really rare moment in US history when policy was designed to intentionally expand who was considered and treated as citizens and who was welcome to participate in our democracy. And as my colleagues and I point out in our book, The Hidden Rules of Race, this period, which was not unlike the earlier period of history known as Reconstruction, was met with very swift backlash. Li refers to the public management reforms that started in the 1970s, and I would just love to spend a little bit of time thinking about the forces that drove these beliefs and sort of eroding trust in the federal government's ability to provide public programs. And I just keep thinking about how during the 1970s and into the early 80s, conservative economists, politicians, and thought leaders really reeled against the increased inclusion and power of previously excluded communities, and also against the allocation of public funds to support those communities. And this really led to the Southern Strategy, which carefully leveraged strategic racism in support of the conservative economic argument for smaller government, increased privatization, lower taxes, and fewer regulations on businesses and the wealthy. And that this incredibly successful political campaign really helped convince wide segments of the population that public goods should actually be private goods, and that the government should be out of the business of our daily lives and out of the business of guaranteeing a floor of well-being for all. So this shift to our current neoliberal economic system relied on what we call a bootstraps narrative that highlighted the importance of personal responsibility and ultimately blamed people for the social and economic inequities they experience. And I mention this because these tropes that really undergirded our neoliberal economic system also fueled the policy shifts that we saw in the 1990s, perhaps most evident in Clinton's welfare reform. And so it's no surprise to me then, as I read this paper, to think about that this is the same time when we see Medicare shift to a more market-driven program with, quote, an expectation to reward people for maximizing their self-interest and their interests and the interests of society as a whole. As Li notes, the claim at the time was that a proper combination of administrative orders and market force could serve as a countervailing power to make healthcare more affordable. I think what Li alludes to, and would be really interesting to spend a bit more time on today or in the future, is the irony of this shift in the 90s, right? This was a shift that would purportedly give consumers and patients more choice and more power. But what we've seen and know now, 30 years later, is that this was actually part of a broader economic trend that has intentionally eroded the power of the state and weakened the power of consumers. As with the rest of the economy, the growing privatization, corporatization, and financialization of our economy, including, and I would say particularly the health sector, has actually driven up prices while failing to deliver higher or quality or more care. And what we've seen is that this has had a disproportionate impact on women, people of color, immigrants, and particularly women who sit at those multiple intersections. And as others have mentioned throughout this conference, these trends have really eroded the scope and power of our public health infrastructure and really made us more vulnerable to the pandemic and the economic crisis that's followed. There's just one other piece that I'd love to comment on briefly and also invite Yifei to share her thoughts. This paper cites experts who argue that people can only value their healthcare if they have direct contribution to its delivery through premiums. This was a real, pillar of the shift to market-based healthcare that we saw in the 90s. And I just want to think about how this concept relies very heavily on the personal responsibility narrative I mentioned before, and also obscures the race and gender inequities, both historical and present day, that drive and are also reinforced by health disparities, right? This notion that we can only value our healthcare if we pay for it seems uniquely American and very linked to our notions of deservedness, economic status, and belonging, right? And this idea that you only deserve high quality healthcare if you can pay for it. And if you can't pay for it, it's no fault of your own. You should just work harder and make more money. That's sort of overly simplistic, but is really the idea that undergirds much of our health and social systems today. And so this idea hasn't only shaped Medicare policy, but also Medicaid policy, and also health and social policies and programs more generally. And we see it showing up again today in conversations around work requirements for important social programs like the child tax credit. So I'll just conclude by saying I would love to hear Yifei and others really reflect on the assumptions that are baked into these transitions that happened in the 1990s about what those transitions would mean for access and quality of care. We've really seen that those promises have not borne out. And I'm curious how folks think we can or might leverage those results or lack of results to transition to a different system or not. So I'll pause there. Thank you so much for allowing me to speak.
Thank you, Andrea, for your insight and comments. I'll invite Yifei to respond to Andrea's comments first.
Okay, as in terms of your first question, which is about how to locate Medicare development in a broader context, perhaps in the past 5 decades, I'd like to first share with you an interesting experience as a PGTA at our institute. I once led a seminar about the New Deal, and there is an argument by Susanna Mettler, and as I quote, "The great achievement of New Deal was the broadening of American citizenship through social and labor legislation to more fully incorporate citizens as full members of the polity." And this argument is quite controversial, as when I discuss this argument with my students, most of them disagree, and they thought African Americans has not been fully incorporated into the American community, and the New Deal actually consolidated the male breadwinner family economy, as there is no entitlement for Social Security for women and colored people, and most African American farmers are not counted as workers. So their contribution have not been fully acknowledged. I want to share with you this interesting experience, as the concept of citizenship has been always changing, and being shaped after, especially after the New Deal, and the welfare state, and particularly the healthcare system, has been a major force that shaped this concept. So I think it is very interesting to focus specifically or analyze the healthcare system from the perspective of citizenship. And as for how to locate Medicare in broader context, as Medicare is a program introduced in 1965, but it has not been a program that has enjoyed a very long history, but actually it has a lot of roots in the U.S. welfare system as a whole. And I think the beginning of Medicare has of Medicare is more about the value of public program, but in the 1990s, starting from the 1980s. Especially during the Reagan administration, there is a general privatization trend of Medicare, and that has, to some extent, eroded the concept of broader citizenship and the universal healthcare, universal entitlement, something like that. And after the 1990s, the privatization has growing more rampant, more quickly, and as for the pandemic or the COVID, I think the root is the new public management reform in the 1990s, as it has weakened the concept of general entitlement, and it has eroded the power of state, and actually it has segregated the different segments of the Medicare system, so which made them hard to connect and hard to work efficiently or cooperatively. So that is my intention to write this essay, and I think it is very interesting to discuss this brought about this issue on this conference. And as for your second question, which is about the co-payment, well, actually, I have a very interesting analogy for that. As you can imagine, what would be like if the automobile insurance is covered by the government, perhaps at a very large percentage, about 80% or more. The car insurers, the car manufacturers will be thrilled, because if the government covers 80% or more of that car, people will not consider the price that much. So they are going to buy more car, and they're going to buy more cars and at a higher price, and it almost give the car manufacturers a license to mark their price up. And so in this sense, if the government covers a very large share of medical care, it means the patients will lose incentive to find the most cost-effective way and the most cost-effective plan for their health. And this is generally an incentive to let the medical system become more inefficient, as the price will surge, and there is no reason for patients to save money for the government. So this is about the co-payment, and if we improve that co-payment, it also has another concern, which is the inequality, as only rich people can afford that high prices of co-payment, and if those less advantaged people have little money to pay for that co-payment, they will generally enroll in a very inconsiderate plan, perhaps. So that is perhaps another way to broaden the to exacerbate the inequality.
Okay, so we do have about 10 minutes for a general discussion, and I see that Naomi already has her hand up. Naomi, go ahead.
Thank you. Thank you for the paper and the comments. I noticed in the paper, unlike Andrea's comments, that you avoid the word neoliberalism. And I think that this is unfortunate, because it moves you away from some very exciting theoretical literature that has talked more broadly both about American neoliberalism and global neoliberalism, especially around health. So I just want to reiterate the idea that, in fact, the analysis, for example, of Clinton's welfare programs and others have begun to be done by people who are identifying a broader social and economic movement in the 1990s. But I guess the other thing that I want to say is, what I didn't get as much of a sense of in your paper, even though I'm very sympathetic to what it is you're arguing, was actually Medicare. So, and it's interesting that in your comments in response, you really weren't talking about Medicare at all, right? You were talking about Medicaid or other kinds of health insurance or something like that. And yet, just to sort of, remind everybody, Medicare has become, in the 21st century, a political slogan for people in America who are arguing for a national health system, right? Medicare for all. They're not suggesting Medicaid for all. Nobody wants Medicaid for all, right? They want Medicare because it's understood as a really successful non-race or income-based system. So I wondered if you might want to comment on that as well.
Yifei,
you can go ahead and comment on.
Oh, all right. I thought Andrea will go first. Okay. I think it is quite an interesting point to say that there is no Medicaid for all, And as Medicare has enjoyed so much has been so much popular since its inception, and it is generally like a social security. It is based on it benefits more generally more middle class and advantaged people in the society. And the reason why I didn't...
No, just to say Medicare is for everyone, right?
Yeah,
everyone. Yeah. Okay, not just
there is a goal towards the universal healthcare, and Joe Biden has introduced a new concept called Medicare for More, and it is generally a more less radical attempt towards the universal healthcare. And the reason why I didn't talk much about Medicare in this essay is that actually this is part of an introductory part of my PhD thesis, and generally I just want to present the theoretical foundation of my thesis. So as the word count is very limited, so I can hardly present more specific details about Medicare in this essay. I think the reason why I come to this conference expecting that I could share with you or perhaps present a more a novel perspective to observe Medicare instead of just talking about its histories. So that is the reason why perhaps you can find you find less details about Medicare in this essay. But if you are interested in this topic, I'm more than happy to talk with you after the conference. So just perhaps I can know your email and I can send you your email. And I think it would be very interesting for us to share our thoughts, perhaps.
Andrea, you have your hand up.
Thanks. I just wanted to respond to one piece about the choice in plans. Is that what we've seen is that actually Americans have fewer choices in their health plans, and that the increased consolidation of the health sector has meant that we just have fewer and fewer options. In fact, I live in the town that I live in, or the district I live in, the biggest health insurer has just decided it will no longer insure the biggest healthcare provider. And it's putting everyone in a very bad spot where 80,000 patients now have to go find entirely new doctors because the largest healthcare provider will not cover our physicians anymore. And it is very difficult to just go and get a new health insurer. So I just want to flag that, and that there just are not an abundance of options because there's so much merging and consolidation in the health sector, both in terms of health insurers and also in terms of health providers, right? As hospitals sort of take up smaller providers. Now, almost every provider in my district is part of one large health system. And so there is actually almost no option for where you can get care or who will insure you. And I'll also just flag that I think the research shows that any premium at all is a deterrent for accessing healthcare. And that goes for wealthy people too, that even those in the highest income brackets in the United States will delay or avoid seeking care, even if they have a small premium or copay. So, I think the research just really bears out that this idea that we will only value care if we pay for it, it's just deeply flawed. And I think, Yifei, in your future work, it would just be really beneficial to highlight that. And I do think we're in this moment where so many of those assumptions that were baked into the social and economic policy reforms of the 90s have proven to be false. And sorry, so just highlight that research around cost and premiums and it being a deterrent for accessing care.
Thank you, Andrea, for that. I wanted to kind of follow up on that and on something that Andrea said during her first round of comments. And that is that if you look at the track record of the neoliberalization of American healthcare, including Medicare, then it clearly has not delivered, right? I mean, anybody who would look at anything like statistics or the choice has not expanded for consumers, and the care has not expanded, and it even sort of eliminates certain groups, more vulnerable groups from healthcare. So if the track record is so abysmal, I'm wondering, how maybe the discourse about, especially among supporters of continued neoliberalization and continued gutting of Medicare, let's say, how that discourse has evolved over time. I mean, clearly they can't look at statistics and say we're doing so well. I don't think most Americans would believe that. So what kind of, how's the discourse among supporters of this, the new public management changed over time? I mean, has it shifted more in the direction of, let's say, cultural arguments, let's say, rather than economic arguments? Because the statistics just don't bear out. So I'm wondering if you've noticed any trends in that. Oh, sorry, I was asking you.
I'm happy to comment, but if Yifei wants to go first, I'll pause.
Yifei first.
Well, actually, I may in no position to share my thoughts on the general trends, as actually my PhD thesis is just focusing on the 1990s. So I think Andrea may have more interesting points. Sorry for that.
Mm-hmm. Thanks for that question. I think it's a really important one. I would say two things. One is that I think the shame around accessing public programs in the United States, and perhaps less around Medicare, but certainly around other programs, has just been very effective. And that was a real sort of strategic part of the transition to the neoliberal economy, right? Was sort of, you shouldn't need to access government programs. You should be able to do this on your own. So I do think, the neoliberal project has been very successful at creating a dislike of public programs, even among people who utilize them. And I think, my grandfather was on Medicare for the last 30 years of his life. And before he died, told me, I don't want the government having any part in my healthcare. So there is just like a broad lack of understanding about even people who use those programs, that they are like programs that work and provided by the government. I also think, we are in a moment, and have been for a long time, where racism really sort of cuts across and fuels this dislike of government programs. Jonathan Metzl's work, his book, Dying of Whiteness, really elevates how white Americans say, like, I would rather die than have someone else have access to free healthcare. Like, I don't care that it benefits me. If the other is going to have it, I don't want it. And so that poses a very challenging problem for us here in the United States. And I think, that's why I always bring this question of race and the history of racial exclusion into these conversations, because I think it is a major barrier for us to enacting broader public programs that intentionally include and address the historic wrongs. And I think we are in another such moment, right, where we're having a protracted battle right now about a major spending bill. And really it's about who will be included and who deserves to have access to the money and those programs.
Thanks for clarifying, Andrea. I agree. I think these are more, we tend to view these discussions as sort of centered around the efficiency of healthcare and which model is designed to be the most efficient. I don't think that's actually the nature of the discourse, and I don't think that's how many Americans understand it. I think they understand it in cultural terms, which are not necessarily rooted in logic, or even a good bottom line in their own pocketbooks. So I think that's really important to what Andrea said, to sort of consider the broader context of these policies and of the discourse surrounding these policies when you're researching them. Okay, thank you. We're out of time again. So thank you very much, Yifei, for sharing your research with us. And thanks, Andrea, for those insightful comments. We are going to take a short break I see in the program, so we're going to come back in half an hour at 4:30 for the last two papers in panel 5 by Nancy and Olga. So everybody can go ahead and log out. We'll have a 30-minute break and we'll come back at 4:30. Thanks, everybody.